So I'm sure people will continue to trickle in, but I think maybe just in the interest of time, we can go ahead and get started. I just want to welcome everyone to the Cambia Palliative Care Center of Excellence Research Grand Rounds today. And I have the pleasure of introducing Dr. Cara McDermott, who is an assistant professor in the Division of Geriatrics and Palliative Medicine at Duke University School of Medicine, with a secondary appointment in the Department of Population Health Sciences. She's also a senior fellow in the Center for the Study of Aging and Human Development at Duke, a member of the Duke Cancer Institute, and a research scientist at the Durham VA GRECC. Is that how do you pronounce that acronym? Prior to coming to Duke, she completed a T32 in palliative care research and a K12 in implementation science at the University of Washington, where she was an acting instructor in the Division of Pulmonary, Critical Care, and Sleep Medicine. She is a former affiliate member in the Cancer Prevention Division at the Fred Hutch. Her research centers on medication and symptom management for older adults with life-limiting illness, especially those with pulmonary disease, cancer, and/or dementia. She has received research funding from NIA, NHLBI, and the VA, as well as AcademyHealth, to adapt and implement medication optimization interventions addressing safety, adherence, and cost barriers. And I will go ahead and hand it to you, Cara, to get started.
Great, thank you so much. So I'm just curious because I'm going to be speaking a lot today about medication, and you can just drop it into the chat. How many of you are regularly prescribe medications to people at the VA, outpatient, inpatient, anywhere? Or do we have a rough estimate? Are most of the people here prescribers? Or you could just react with a thumbs up. Yep. Oh, David. Hi, David. It's nice to see you. Yep. Okay. And I know some of your names, Jackie, Lisa, Claire. Okay, great. Lovely. Well, what I'm going to talk about today are two particular disease states that I work in now more than ever. And they are COPD and dementia. And I'm going to start talking with dementia. And one of the things that has changed very much for me now, being in North Carolina versus Seattle, is that when I worked in Seattle, I largely looked through healthcare at healthcare through an urban lens, if you will. And now being in North Carolina, the majority of our state is actually rural. And being at Duke, many of our patients come to us from South Carolina and rural areas of Virginia. So rural health has now become a major concern of mine because it is something that is so important and far-reaching. So for today's talk, I'm going to start talking about dementia care and dementia medication safety in dementia. And then after that, I'm going to switch to talking about COPD. And so one of the things that I'm going to be talking about with COPD is to back up and talk more about the outpatient setting. So today, the things that we will be talking about are largely around rural healthcare and dementia. And while I realize that at UW, Seattle's a very urban area, also being in the WAMI region, I'm sure that those of you who practice in the VA and those of you that practice at places like Harborview do encounter folks from rural areas often who receive their healthcare at UW or at outlying clinics. So I'm going to share my screen now with that introduction, and we can get started. And at any time, please feel free to drop questions in the chat, and I will be looking for them as well. And Helene, thank you for joining. I appreciate you being here. Okay, so in full disclosure, I'm an editorial board member of the American Journal of Hospice and Palliative Medicine, and I'm also a research consultant for a nonprofit that works to bring biosimilars into more use and to test their safety and efficacy in larger populations so that we can provide folks who may take specialty medicines with more affordable options for care. So, how does dementia impact medication use? I'm going to be very from the ground up here in this talk. So as cognitive impairment progresses, reduced ability to plan, organize, and execute medication management tasks may result in unintentional non-adherence, medication errors, preventable medication-related hospital admissions, and dependence on family caregivers or community nursing services to assist with medication management. Now, this also brings up an important policy issue for those of us who work with people with serious illness, and that is that with the shift to home care in recent years, we're now seeing policy implications of this, where now caregivers might be able to be paid by certain state Medicaid programs to take care for people in the home because nursing facilities are simply overwhelmed. So in North Carolina, for example, we have an ongoing project where we have family carers that receive a bit of training, and that's a little generous, honestly, and then they can take care of a loved one with dementia in the home. And the goal is to keep them in home as long as possible. And part of the reason for this is that we need direct observation and assessment. So opening medication packaging, identifying medications, and assessing the ability to swallow. And I will challenge some of these programs by saying that dysphagia can be very difficult to observe consistently when it is starting. And also somebody who is a family caregiver who doesn't have training as, a geriatrician or a speech pathologist or an occupational therapist can miss a lot of these things. So we certainly have a lot of concerns about so much dementia care switching to the home setting. Additionally, older adults with dementia are 3 times more likely to be hospitalized with medication-related adverse events versus people without dementia. Now, there's a number of common problematic medications, and if you look at this list, very few of them are actually for dementia. So anticoagulants, anti-diabetes agents, antihypertensives, NSAIDs, opioids, proton pump inhibitors, none of those are considered dementia-related medications. However, antipsychotics are commonly used to treat behavioral and psychological symptoms of dementia or BPSD. However, most of the medications are actually from comorbidities. Now, people with dementia more frequently receive potentially problematic medications. So, as we can see here, this is a paper by James Deardoff up at UCSF, and he looked at people with dementia and people without dementia, and didn't only look at inappropriate medications, but also over-aggressive treatment of chronic conditions, which ties back to my last slide, that you can have people who are still receiving very aggressive, for example, blood pressure control, when it may not be that important at this stage if they have life-limiting illness and if their blood pressure is not extremely high. Additionally, we also have medications that negatively affect cognition. So we can have folks who are taking medications, for example, opioids that affect cognition, but they also are now they're experiencing dementia, but the medications that we're giving them, which are well intended, further impact their cognition. So it's important for us to think of dementia care and medication safety as nuanced and multifactorial in this population. Now, again, as we shift medical care to the home setting, major themes in symptom management include the patient-provider relationship, open and honest communication, accessibility of resources during hospitalization and at discharge, caregiver support training and education, and care coordination and follow-up care. Now, this is from a survey of caregivers and clinicians. And for me, the last two, caregiver support training and education, and care coordination and follow-up care, is a large part of what I'm working on with people living with dementia and their caregivers. Now, why dementia again? Well, not only is it highly prevalent, but also caretaking in dementia is common and costly. So right now, about 11 million Americans are providing unpaid care for people living with Alzheimer's disease and related dementias. They estimate that these folks give about 18.4 billion hours of care in 2023, and the monetary value of this care is valued at about $350 billion. So one of the things that we really need to accept when we talk about this is that we simply do not spend the resources we have right now in a way that we can actually provide this care in institutional and hospital settings. Right now, institutions and hospitals are already strapped for cash. So unpaid caregiving is the backbone of dementia care in the United States. But 70% of these dementia caregivers say coordinating care is very stressful, and 74% say they're concerned about maintaining their own health since becoming a caregiver. And about 2/3 have difficulty finding support for their needs. So I bring this up because This is a graph from 2024 by a home health group called A Place for Mom. And they list the 10 least expensive states for home care. Now, these are median hourly home care costs. North Carolina is not on this list because our average cost is about $30. Washington State, last I checked, is higher at about 34. But if you think about it, if you need a break for, say, 10 hours a week, even living in Louisiana, that's $210 out of your pocket. You might not be able to afford that. Multiply it by four, that's $840 a month. And that comes out to be about $10,000 a year. And we're only talking about 4 hours. So even if people want a release, if they need support, they may not be able to afford it, whether out of pocket or coverage for caregivers through government or insurance sources. And I also want to bring up financial toxicity because this goes to support for caregivers, and support for caregivers impacts patient safety, including medication safety. So, one of the things that we need to be aware of is that things like direct costs of care then cost caregivers and patients more in terms of indirect costs like lost time in travel and time off, which is especially important since many of these people are sandwich generation, meaning they're caring for older adults and children. This in turn results in financial toxicity and depression, anxiety, decreased quality of life, and cost coping strategies, along with treatment noncompliance. And that is not just for the patient, but for caregivers as well. So going back to North Carolina, most North Carolina counties are rural. 78 out of our 100 counties are in fact considered rural. Now I am sitting over in the two blue counties that between the orange, that would be Durham and Orange counties. And then we have Wake County, which is orange, which is where our seat of government is, Raleigh. The other one that's orange with blue in this, the Charlotte area. But as you can see, the vast majority of our state is rural. And unfortunately, with rural hospital closures, that in turn affects dementia care. So if you look again at this graph, we're looking at different rural health programs and hospitals that have closed in recent years. And if you look at North Carolina and South Carolina, where I'm working now, we have a preponderance of closures. And these are closures that are not just inpatient hospitals, but also skilled nursing facilities and standalone ERs. And when this happens, you have more rural caregivers who are on their own, who aren't sure how to respond to issues that might arise regarding medication and home care. Rural people living with dementia also spend more time in nursing homes versus urban dwelling people with dementia. So one of the things that we see here is that the time after ADR diagnosis in the first graph for home health is about the same. However, nursing home use is very different. Hospice and hospital use, however, are similar. Now, why do we see such a gap in terms of nursing home care for people living with dementia? There's multiple positive reasons behind this, but one of them is simply that there's not enough home health agencies or hospices in rural areas anymore to provide in-home care. Additionally, with an exodus of people from rural areas to more urban areas in search of job opportunities, you simply don't have the workforce or the family members to care for people at home any longer. Now, caregivers, when they are able to keep patients at home, are concerned about patient safety. And identified issues around caregiving for community dwelling people living with dementia include medication errors, miscommunication between professionals, unclear service pathways, and the effects of stress on caregivers' behavior. So what does unclear service pathways mean? For example, that can occur when there is unclear payers. So if somebody is dual eligible for Medicare and Medicaid, they may not realize that one covers a certain service or home health or durable medical equipment versus another. Or for somebody who's enrolled in hospice, whose family might call emergency services multiple times and risk being disenrolled. Now, all caregivers were able to identify actual and potential safety problems, but few had formally reported them. And some caregivers were concerned that people with dementia would not be able to report safety issues. So factors impacting safe medication use include changes made by caregivers. So sometimes caregivers may change a medication dose or substitute other medications, either because they're simply not aware that they're making a change, or they're making these substitutions because they have run out of a medication, or they don't feel comfortable. For example, caregivers note that they're very uncomfortable giving subcutaneous medications or crushing medications as needed. Caregiver health and cognition is a major factor. When we think about medication safety and dementia, we also have to think about the ages of those involved and the comorbidities. You may have a spousal caregiver who has mild cognitive impairment along with a spouse who has dementia. And also changes of medication formulation. Not only do these impact caregiver understanding, but impact patient compliance. And we can see more of this as dysphagia, for example, progresses in dementia. If we keep people on certain medications and maybe we change the formulation to liquid or buccal, they may actually balk at this. Or it could be as simple as CVS refilled the medication and it looks different. We see this a lot, for example, with thyroid meds. So in this study, a caregiver said the patient refused their medication because now it comes in a different form. And the tablets, he says, no, this isn't my tablet because he doesn't recognize it. And for those with dementia, routine is important. And when you lose routine, you also may see an increase in behavioral symptoms. I also want to briefly talk about second victim phenomenon in caregiving. So, a second victim phenomenon is actually referring to healthcare workers who experience negative effects after being involved in an adverse event while caring for their patients. And examples of adverse events are often things like medication errors. So, among caregivers, 58% in one study experienced second victim phenomenon, and 35% experienced a prolonged effect. 45% still suffered from it. And when they compared the results of talking to people who were in-home caregivers compared to professional nurses, the researchers found no significant differences between caregivers and nurses. And the things that caregivers reported as second victim phenomenon events included things like worrying about adverse effects from medication because they had made a mistake, running out of medications, and also things like falls and injuries to patients where the caregiver was either unable to catch them or were concerned that the medication they gave them could have been an overdose or something that contributes to the injury. So, what do caregivers want for medication programs? Well, the major themes for content are critical medication information that is accessible, medication effects, medication indications, disease progression and impact of medications, and safe and appropriate administration. Now, one of my other projects, which I'm not going to discuss today, is actually in the VA, and we're working with rural caregivers of the Chimes in this program called Chimes that are enrolled in a caregiver program for caregivers of veterans with dementia. And the single most frequent feedback I get is that the medication information is helpful, but I'm not able to understand it. And when we talked to people, we realized that the medication information we were giving them was at a 12th grade level. However, the average reading level in our rural caregiver population in North Carolina was 5th grade. So we were doing our best with providing the information. However, it was simply not understandable from the caregivers that we were giving it to. Additionally, caregivers wanted to know more about what to expect with the Alzheimer's trajectory and what would happen next and how that would impact medication so that they could get ahead of it. But too often we think of the here and now when we're talking about medication use rather than thinking forward and maybe starting to think in terms of incorporating goals of care into our medication use. Now, rural caregivers also, I want to emphasize, are a bit different because they are very dependent on place-specific services. So facilitators to using place-specific services are presence of friends or family to help and living in a county with home-based services. However, in many rural, close-knit communities, barriers about using these services include guilt about using limited resources. We see a lot of folks who minimize their needs and saying, no, my neighbor, my church member, the person down the street need these more. Internet and cell access is still a very big issue, which I realize in Washington State, that's really a above 90 issue for many folks. But in North Carolina, we have large swaths of folks who do not have access to broadband still or Google Fiber or any of that. And also, of course, distance to provider. So I mentioned Chimes briefly. And so what I'm doing with Chimes is actually looking at national Medicare claims data and identifying areas to improve medication safety. And so what I'm looking at are potentially inappropriate medications and then seeing how this might impact emergency department visits, hospitalizations, and SNF admission. And of course, we're looking at comorbidities and things like distance provider, marital status, race, and sex. And we actually have some of our findings finished, and I'm presenting them at Academy Health in a few weeks in Seattle. So if any of you are going to Academy Health, please look me up. I'll be there. But one of the things that we found was that in rural areas, we had a much higher use, a statistically significant and clinically significant use of benzodiazepines among people living with dementia. In addition to that, we also had much higher use of opioids. Now, the interesting thing about this is that we controlled for everything under the sun and also did cumulative incidence with propensity score matching, and we accounted for the competing risk of death. So really what we're looking at here is that over time, we start using more of these medications, which is not surprising. As serious illness progresses, we often do use these medications more. However, accounting for everything except virality, we see this difference. And then when we have a heat map in progress, which it wasn't ready for today. But when we look at it, there are clear overlaps between some of the uses of these medications and rural hospital closures that I showed in my previous map. So now we're also doing qualitative interviews to see, is this overlap something that is happening because people don't have access to care? And we essentially need to control symptoms in the home because we don't have other options. Or is this because of prescribing patterns from local resources that may benefit from things like academic detailing and interventions? So before I switch to COPD, the other thing I wanted to add about our Chimes analysis is that the most common comorbidity that predicted potentially inappropriate medication use among people living with dementia was COPD. And so this is near and dear to my heart because geriatric syndromes are common for patients with COPD, and it is a condition that's very stigmatized, that we frankly have very limited effective medications for. And it's something that is not given a lot of concentration versus other serious illnesses. So we hear a lot about heart failure and advances in heart failure medications, kidney disease, cancer, but with dementia and COPD, we really have very limited options. And despite spending money on many of these, we don't have good, safe medications that are tested in the people most affected by these conditions. So, being in geriatrics, I always like to talk about geriatric syndromes. So, for those of you who may not be familiar with this, geriatric syndromes are conditions and multifactorial symptom burden that disproportionately affects older adults. So, things like multimorbidity, functional disability, falls and frailty, impaired physical function, and severe polypharmacy. And all of these are actually very common. This is a COPD population that generated these numbers. So how do we get to polypharmacy in COPD? Well, first, if we follow guideline concordant care, patients should be on an inhaler. But when they have an exacerbation, then we often treat them with antibiotics and corticosteroids. And after they're stabilized inpatient, they are discharged and are typically continued on these meds. Now, I mentioned multimorbidity. Guideline concordant care for the comorbidities typically involves multiple medications as well, such as diabetes, heart failure, or hypertension. So it's not uncommon to see a patient with COPD with an inhaler and also between 8 and 15 oral medications. And finally, the common symptoms in COPD, plus or minus comorbidities that may exacerbate these symptoms, include things like dyspnea, insomnia, and pain, which are all notably difficult to treat. So when we have dyspnea, we might be seeing more benzos and opioids on the uptick. Insomnia, we have benzodiazepine receptor agonists, so that's like zolpidem, for example, and tricyclic antidepressants or trazodone, and pain. So we have opioids and NSAIDs. And for those of you who are in geriatrics, the Beers criteria and STOP and other deprescribing or medication assessment tools, you see a lot of those medications that we typically flag as concern of use in older adults that are on this list. Now, polypharmacy is risky for patients with COPD, and it's associated with higher costs and medication burden and lower quality of life. And one of the things that I am particularly interested in now is falls. And you might say, well, why falls of everything out there? Well, unfortunately, many falls are precipitated by risky medication use. And medication use, as you all are aware, when you are faced with life-limiting illness and you are facing more decline, more frailty, a change in fat disposition in your body, and also renal and liver function decreases, you're more likely to experience an adverse event from medications. So, this is an analysis I actually did with Ruth Engelberg and Randy Curtis when I was still at UW. And I looked in the last 2 years of life of patients living with COPD and multimorbidity, and 65% of them were using a FRID. And a FRID is a fall risk increasing drug. So, whereas PIMs, or potentially inappropriate medications, are things that we think about with the Beers list criteria, FRIDs are more encompassing. So, for example, something that might be appropriate per Beers list, like an ACE inhibitor, is also a FRID because FRIDs can promote falling. So diuretics and certain doses of ACE inhibitors are actually FRIDs as well. So I looked at those who had COPD and were using FRIDs, and overall 30% fell in the last 2 years of life. And when I say they fell, I mean that they experienced a fall that necessitated medical care. Now, if we look at those with COPD versus without, the use of anticonvulsants was higher, as well as antipsychotics and atypical antidepressants, as well as tricyclic antidepressants. And when I say atypical, I mean things like mirtazapine and bupropion. And the FRID burden, as the FRID burden increased, meaning for each additional FRID added, you saw a 7% increase in risk. Now, when I went to Duke, I looked at FRID use among people with COPD here. And we actually have multiple dashboards, and one of which in the Department of Geriatrics was developed by my colleague Juliessa Pavan, where we flag people who are at high risk of falls. So among those with COPD, we have about 76,000 patients age 50 and up who have had 15% of those have had a fall-related visit. So 76,000 patients with COPD, age 50 and up, and 15% had a fall-related visit. Now, among that group, 19,000 of those patients were age 65, and they were at elevated fall risk. And what is that? That means that either they've disclosed a fall on their annual Medicare wellness exam, or they have experienced a fall requiring medical attention. Now, of those, they had active FRID prescriptions. So 19,000 patients with COPD and at least one FRID on board, and 10% of them experienced falls. So what were the most common medications? Well, we see diuretics, antihypertensives, opioids, and anticonvulsants. Now you might say, wow, anticonvulsants, 27%. 27% of people with COPD do not have epilepsy or other, for example, brain injury-induced seizure disorders. 68% of that was gabapentin. And this is also something that has spurred my current research portfolio around the use of gabapentin as as an add-on or substitute for opioids. And the common comorbidities associated with FRID use in our population were anxiety, chronic pain, depression, and insomnia. Now, again, going back to this group with COPD, 65 and plus, and high fall risk, 82% of them had at least one of these diagnoses. And I mention this because I want to bring forward that while we say, medication safety is important and maybe deprescribing to reduce risk is important, these are also comorbidities that are incredibly difficult to treat. So we're up against a lot in the process here. Oop. And gabapentin can also be for cough. Yes, that is very possible. The interesting thing about gabapentin for cough is that the data are actually pretty limited. We don't have good trials about that. And there is a targeted trial emulation ongoing now, which has very mixed results for gabapentin for cough. Okay, so here, what we looked at in the Duke cohort was that we looked at what happens when you add on these meds. So essentially, this is kind of like I don't know if any of you are old enough to remember Choose Your Own Adventure books, but if we are going to choose an adventure for these medications, what we did was we actually started with opioids because opioid use was so common and it's also recommended per guidelines. Then we looked at, okay, if you're on an opioid, and then we split you into anti-anxiety meds. Either you're on an opioid or not. Then we say, okay, you're taking an anti-anxiety med, which in this case is benzodiazepines. Then we split you by antidepressants, SSRI, SNRI. And then we split you by anticonvulsants, which it can be levetiracetam, it can be gabapentin. What we see is the adjusted hazard rate depends on the combination of medications you're taking. So you have a higher risk of falls, obviously, if you have all four on board, and that makes sense. You have four fall risk increasing drugs. But then next up, we see that reducing the anticonvulsant doesn't make that much of a difference. Looking down again, what we see is that anti-anxiety drugs, taking those out of the equation, don't make much of a difference because we have no anti-anxiety on board, but anticonvulsant here, and we have a 2.37 risk. Reducing that to 2.34 if we remove the anticonvulsant. Again, not a lot of change. And then what we have here is no opioid, but yes to the rest. So these are our highest adjusted hazard ratios. As you can see, there are other statistically significant ones here, but the important point being that in this work, opioids and antidepressants, alone or in combination, stood out as raising risk. Now, again, we see those that are not significant. And so here, not significant for this pathway, once we removed the antidepressants, you had a lower fall risk. Lower here, if you remove the opioids, you had a lower fall risk. So you can see that one of the things that we're looking at are opioids and antidepressants, what type of antidepressant matters. And because we pooled SNRIs and SSRIs, it looks like actually SSRIs on their own raise risk a bit more, but SNRIs in combination with opioids also raise risk. So the highest risk-free combinations, basically, this is just breaking it out into a table, as you can see here, is that antidepressants raise the risk, but the combination is what matters. Additionally, combinations with no association of falls. So here we have a bunch of benzos and no association of falls that we found, which was quite surprising to me. So what does this mean? Well, first of all, we have to replicate this more in targeted trial emulation in larger populations. And I would never, ever, ever say take anybody off an antidepressant. But it does mean that if you are prescribing antidepressants, to do a fall risk assessment with people. And perhaps for those who are not bedbound, for those who may have limited mobility, things like strengthening exercises and mitigating fall risk could help avoid a fall for them. So I realize I'm at 3:35 now, so I wanted to talk briefly about patient goals and deprescribing. So deprescribing is something that has taken off in recent years in geriatrics and palliative care literature. And one of the things that we always want to keep forefront is that in goals of care, we should align not only our treatment goals with patients, but also their day-to-day symptom management and medication goals. Obviously, I'm preaching to the choir here about this, but I think it's important that when we're doing things like a medication reconciliation, that we identify essential medications. And oftentimes I hear in my care coordination work with folks with COPD, like, oh, I'm not going to touch this because the benzos, the opioids, the fentanyl patches, I give that to palliative care, but I'm going to manage things like the blood pressure meds. Whereas I hear palliative care saying, well, I want to defer to primary care or cardiology for some of these other meds. And so that is something that really we need to think about in terms of care coordination in our health system, and I suspect others as well, that deferring to the person who prescribed the medication is very important. However, there are times where we need to have more communication about these medications that perhaps some of the medications could be reduced or could be discontinued, especially if they might be aggravating symptoms, increasing risk, or are becoming unaffordable to patients. And that's a pretty dreary thing to bring up. But the reality is that if a patient has a life-limiting illness, and medication costs are a concern, that's something we need to address as part of whole person care. So I'm going to briefly talk about medications in hospice use because I know that many of us working in geriatrics and palliative care overlap with hospice, but don't necessarily work within hospice. And one of the things to be aware of are hospice emergency kits when it comes to medication safety. So common hospice emergency kits will contain things like pain, like morphine, morphine for pain, lorazepam or other meds, diazepam for anti-anxiety. Levofloxacin is not as used now, but has previously been used in hospice emergency kits. There is concern about antibiotic stewardship now with that, and things like promethazine and haloperidol. Now, of the five things I just noted in hospice emergency kits, all of them, except antibiotics, are associated with higher risk of falls. So that's not a fall is not necessarily a concern if somebody is bedbound. However, people are not typically bedbound all the time until the very end of their lives. So one of the things to be aware of is that sometimes emergency kits are used in hospice care, and we're not fully aware of the exposures. So what do I mean by that? Well, in a study of home hospice health records, about 50% of the time, hospice emergency kit use is accurately identified and documented. However, nurses have estimated that about 65% of utilization is more common, so we have a gap there. But there's a strong support for hospice emergency kits among caregivers, among clinicians, among nurses, with 93% feeling that it avoided hospitalization or an ED visit. But then we also have to think about things like diversion, which is 18% believed someone else in the household was using it. So while hospice emergency kits are great, they also may cause some problems. I am not advocating for them to be removed. I'm not advocating for stricter use of them. Rather, I'm advocating for clinicians and caregivers to be aware of potential issues, and that with greater communication, we can track people who may be receiving hospice care at home, may have access to an emergency kit, but are still out in the community, so that may encounter these folks, and we want to ask about these things. Now, when it comes to barriers and facilitators to deprescribing among palliative care patients, there's patient level factors that we need to think about in terms of withdrawal and return of symptoms. But again, values and preferences matter: cost, pill burden, perceived necessity. There's prescriber factors like rational knowledge of deprescribing guidelines. So training and guidelines can help us with that. But there's also non-rational experience-based care. And in palliative care, unfortunately, we don't always have a great evidence base for some of the medications that we use. Some are off-label, some have small cohorts. And part of that issue is simply because the way that drug testing is in the United States, we don't fund large randomized trials of medications that are cheap and available and medications that are used in populations with limited life expectancy, unless there's a high cost for that medication involved. And that's unfortunate, but it's the way evidence base is generated in the United States. The other things to think about with deprescribing are system level factors like resources, a presence or absence of a pharmacist that you can loop in for help. Goals are patient safety and a culture of care coordination. And that goes back to what I talked about before, is that many of these patients with serious illness are living with multimorbidity, and they may have multiple prescribers on board. So having palliative care involved is helpful as somewhere where we can go for one source of information, the person who's really running the show, if you will. However, that is not always the case, and people who receive their healthcare through multiple systems, like at Duke, we have patients who might go to UNC, who might go to UVA, who might go to ECU, who might go to Wake Forest. It's really hard for care coordination when we start talking about deprescribing because we don't have the full picture. But prescribing is a common focus of de-implementation, and de-implementation is something that's becoming more common in health systems. So why prescribing? Well, it can be lower risk versus procedures or screening that might be more common that might be more evidence-based fruitful for de-implementation. However, they generate more revenue and are more expected. So an example of that is breast cancer screening past the age of 80. Prescribing has a lower threshold to restart if needed. And ineffective de-implementation can give us concerns about rationing care. Like, for example, when I talked about cost before, a lot of times when I bring up cost in these talks, people get really shaken or taken aback. We don't want to ration care ever. But the reality is that when we have exhausted opportunities to mitigate costs for patients and their families, this is something we need to address because it may not be in their goals of care to go bankrupt for a drug that may give them 1 or 2 additional months of life. Coupling de-implementation with implementation can also help negate a sense of loss. So, for example, if I'm talking about de-implementation in the setting of serious illness, we might focus on instead is what can we substitute? Can we substitute in physical therapy? Can we substitute in, instead of the 3 medications you're on, one now plus a non-pharmacological option? And that can sometimes help with de-implementation. Slower reduction and non-pharmacological alternatives, but also social support. One of the things that I'm particularly interested in now is how social support can facilitate and enforce deprescribing and medication safety. Folks like Ashwin Kotal at UCSF are looking into social isolation. And social isolation and COPD, one of the biggest predictors of social isolation and potentially risky medication use in COPD happens after people start supplemental oxygen. And this is because their world typically shrinks, and it is also a red flag that they're not doing as well as they used to. So these are things that we need to think about all over when we're talking about medication use and ways to increase medication safety in these folks. So finally, reducing risk, you can identify low-value medications that might not align with guidelines, that might not be concordant with life expectancy or goals of care. And we want the benefit to be greater than potential harm, and that's not always the case. So the Beers criteria could be one. Stop Frail is another tool. There's also a tool called OncPal that was generated in Canada that can help with reducing medication load among patients receiving treatment for cancer. And potentially low-value medications often used among patients with COPD include benzos, inhaled corticosteroids, tricyclics, and hypnotics and sedatives. The evidence base for these, compared to other alternatives and non-pharmacological care, indicate that these are actually at higher risk than benefit. So that is what I have today, and I'm happy to take questions and thoughts. I saw something in the chat. Frankly, mixed results for lots of things. Yes, thank you, Caroline. I'm going to escape from my slides so I can see folks, but absolutely. One of the things I'm looking at right now is gabapentin use in skilled nursing facilities. And in talking to folks, a lot of them say, especially with people living with dementia who might have limited recall or limited verbal ability, gabapentin can be helpful with BPSD. But we also know that gabapentin promotes respiratory depression, especially in conjunction with opioids and respiratory disease. So there's a lot about gabapentin that we love. It's our new it child because it's not an opioid and it's not an antipsychotic. So especially in places like skilled nursing facilities, it's less scrutinized. However, I was really shocked to see 68% of people in the cohort at Duke receiving gabapentin. So. Okay, well, I have talked everybody's ears off. It's 3:45, so I would love to hear if you have any questions or concerns or just want to, chat, disagree, agree. Tell me how the weather is in Seattle. Yes, David. So nice to see you.
Really great to see you. Thank you so much for
Oh,
coming back
I can't
to.
hear you. Is it just me?
David, yeah, I actually can hear you. So I don't know if
Oh,
can you hear me, Kara?
oh. Let me take off my headphones. Maybe that's it.
Can you hear me now?
I can hear you, David.
Yes, sorry. This is me. Clearly, I'm the problem. It's me. Sorry, David.
How about now?
I can hear you now. Thank you so
Okay.
much. Sorry about that.
Okay. Yeah. Thank you. Well, it's great to see you, and thank you for coming back to talk with us. I guess I'm thinking about sort of a big picture question,
Yes. Mm-hmm.
and coming from the VA and seeing how much care we are farming out to community care.
Mm-hmm.
And this is very relevant to your rural population,
Yeah.
all of your rural veterans who
Mm-hmm.
may find that it's a real trek to get into even
Oh,
a
yeah.
community-based outpatient
Mm-hmm.
clinic.
Mm-hmm.
Um,
Yep.
how do we set up systems of care to do even the things that we all believe in, like deprescribing and
Yeah.
kind of the principles that you've outlined for us are really key principles. But if we can't
Mhm.
reach across systems to implement, then we're going to be missing these opportunities. I'm wondering, do you have some thoughts on how to build those bridges? I don't know anybody that we refer to in the community who gets community palliative care. And, I rarely know a primary care provider outside the VA system. It does happen, but not often.
Absolutely. And that's one of the, I mean, we have so many issues right now. One is the availability of community palliative care. One is allying with folks who are trained in palliative care principles and also those who embrace deep prescribing, which is not as common as you might think. And so, in terms of systems, unfortunately, if we want to see real change, it's typically that there has to be a case made that is a business case or a return on investment. And so, part of the evidence generation that we need is to show that some of these policies, do work. And what I mean by that are things like caregiving at home for Medicaid, and also increasing care coordination. Now, one of the things that we've tried in the past, for example, in the oncology space, is Medicare. The community, we have the hospital at home demonstration project, but we also have, care for cancer in the community. And they have very mixed results. And part of that, I think, is that we haven't thought about thoughtful adaptation in that we have a care model and we apply it equally to rural and urban areas without thinking in terms of provider buy-in, local culture, and also training that's available. So, you mentioned with veterans here, I was familiar with Seattle and American Lake. And here we have different visits that overlap. And we also have some places where people have to drive 60 miles for a primary care appointment because we literally have one clinic that's out in a place that I know that I'm familiar with because it's a red fox sanctuary. So it's one of those things where we're not going to be able to recruit and retain people there. So one option around that is telehealth. But we also have to think in terms of how do we incentivize care coordination and incentivize a system that works. And I don't think we're going to get there with what we currently have, unfortunately. I'm in the deconstructed and rebuild camp. But while we are flying the plane and still providing healthcare, I think that encouraging talk between EHRs is great. But I also think that what we need to do is really invest in primary care. We need to invest in geriatricians, and we need to invest in principles of community health. And so, some of the things that are promising in North Carolina is the use of community health workers. And in my dementia work, which I didn't have a chance to bring up here, we're actually working with churches because we went into rural areas and asked, who is providing dementia care? And it was shocking to hear how many folks are getting informal support and dementia care through their faith communities. It wasn't something I thought about, but if you have a local pastor whose congregation has experienced dementia, there's support systems that they've built around it because there's nothing else. So the reason I bring this up is that we need to be creative about our solutions. And up to this point, we really have thought about it in terms of what do we prescribe, what do we take away, and what symptoms do we treat. But I would advocate that we need to redo the system for whole person care, investing in primary care, rural care, social care, and psychological care. And when we do that and we actually foster a sense and invest in things and value things like community support, then some of these medication safety issues and other problems may fall by the wayside or may not become as serious because if we have eyes on in the community and we have people trained and we have people who understand who are accessible, that can change a lot. Is that going to happen anytime soon? No. I hope that should my children go into healthcare, it will happen in their lifetime. We'll see. Um, but but meanwhile, I think things that we can do are think about things like signing up for the American Geriatric Society and Academy Health's action items. So I have become more involved in recent years. And there are great action items about bills in Congress and things like Medicaid at home demonstration projects that you can support for your patients. Obviously, do it on your own time. Don't use UW resources and all those other things I should say. But those are ways I think to feel empowered with everything that's going on in the world today.
Thank you.
And if I see you at another conference locally, I can opine more with
Yeah.
other things that might be helpful, but not in grand rounds.
Curious, Kara. I feel like this is kind of embedded in what you were saying, but I'm interested. Disclosure, I'm a social worker,
Yes.
but
Yes.
curious about thinking about interprofessional colleagues. Like curious
Hmm.
if like the role of pharmacists in rural areas, or if there are other sort of community embedded social workers and such that might be a part of this
Hmm.
network of solution.
Absolutely. I think we need a more decentralized solution, again, with more community health support. What I keep hearing is we need to train more physicians and send them to rural areas. That is great. However, that also sets them up for unrealistic expectations because they cannot solve it all, nor should they be expected to. That also goes for nurse practitioners and physician assistants. So I think that having whole person care, especially for something like dementia or something with like COPD that has a high mental comorbidity burden and also physical limitations, I think having social workers, physical therapists, community health workers, is incredibly important. We have a demonstration project using medical students now, who medical students go out with homebound seniors and give them an assessment where they are supervised via video. And that's really important because we are able to reach people in their homes. I think we need to bring back home visits and home care. And I think that having teams to do that, like a social worker plus a nurse, a social worker plus an OT, a pharmacist plus a nurse, is great because then we can pick up on things that we're trained to pick up on. I mean, there's been plenty of times I've been in a case conference or something where somebody brings something up and oh, for example, so I was in a case conference where people were very concerned, or actually, they weren't concerned, and I was concerned because a person's A1C went down very rapidly. And I was like, oh, this is really strange. Do we rerun it? And it was accurate. But their A1C went from like a 9 to a 5 in 6 months' time. And so for diabetes care, that's really, really a big drop. And it's also in somebody who's frail and older, an unnecessary drop. And then they brought up that their insulin had been, they'd asked for insulin sooner than anticipated. And when we teased it all out, what we realized was that there were three caregivers now in the home and they weren't communicating. And so everybody was giving insulin. And that's why their A1C dropped so precipitously. And that's also why they had been hospitalized for low blood sugar. So I think it's things like that where we do a more comprehensive evaluation. That's what geriatrics is all about. And that's why I love it. Same with palliative care is if we think about, the social situation in the home, cost, physical function, mental function, emotional function, then we can get a better whole person evaluation and provide them with better care. So I am a huge fan of interdisciplinary teams, and I think everybody should have access to a social worker. But that's me.
Well, I concur. Gonna see if there's anyone in the room who is interested in has questions or comments before we head out in the last like 2 minutes.
And you have my email, and do feel free if you disagree. If there's anything that you want more information about, please do feel free to reach out. If you have an interest in rural healthcare, I'd love to chat too.
That's
Mid-level
great.
providers. Yes, yes, I love that. Yes, mid-level care for the patient at home. Absolutely. That is brilliant. And again, it's the home care issue because it's fascinating to me how we neglect looking over the home environment. And so that is an access to care issue. It's innovative. That is fantastic. I love that. Also, I just want to bring up this is something that I did not think about until I moved here, but for things like COPD, talking to folks about their living conditions and also For example, here, a lot of folks live in trailers that have gaps in them. And so we were able to provide somebody with aluminum to patch up their trailer, and they had much fewer exacerbations because there was not a bunch of stuff getting into their trailer anymore. So I just want to put that out there as thinking holistically in terms of home care, especially when people are having multiple episodes, can be really helpful. So, yeah. But I love that Shelton's doing that. Thank you for bringing that up.
Great. Well, thank you, everyone. And thank you. Please join me in thanking Dr. McDermott for a great, interesting presentation. We appreciate it. And if you have time, if you can click on that link and fill out an evaluation form, that would be great for this presentation.
Thank you so much for having me. Have a great day, everyone.
Yeah, thanks for joining. Bye. And the weather's fantastic here.
Yeah.
Bye, David.